So I'm going to present a patient tonight. He is a 68-year-old white male. He comes into the primary care clinic for complaint of dysuria, which he states that he's had intermittently for over a year. Over the past 2 months, though, it's become less intermittent. It's become more daily, and these symptoms have worsened. Those symptoms, he states, are primarily burning with urination, um, increased frequency of urination, including nocturnal urination. He sometimes finds that he's getting up 7 to 8 times during the night to urinate, a diminished stream of urine, some post-void dribbling, and overall he just doesn't feel like he's emptying his bladder when he urinates. Of his past medical history of note, he has hypertension, hyperlipidemia, COPD, and PTSD. His meds of note are albuterol, Symbicort, atorvastatin, and lisinopril. His family history is, for the most part, non-contributory. He states that his older brother may have had some prostate issues in the past, but the patient is unsure if they were really prostate issues, what they were, and what happened to them. His surgical history only really includes a vasectomy back in 1975, which he never had any issues with. And his social history, he lives alone with his cats and dogs. He drinks roughly 6 ounces of alcohol, 6 ounces of whiskey every night, and smokes 1 to 2 packs of cigarettes a day. His review systems was, for the most part, unremarkable. He denies any pain other than the pain with urination, no abdominal pain, no anal rectal pain. He denies hematuria, he denies discoloration of the urine, any foul odor to the urine, or exudate in the urine or of the penis at all. He is also not sexually active and has not been sexually active for many years, and no history of STIs in the past. So his physical exam was, again, for the most part, unremarkable. His vital signs were stable. He was somewhat tachycardic. His heart rate was 104 when he arrived, but that slowed down to the mid-90s. He did not have a fever, though he did state that he had some chills and some night sweats, but states that the night sweats are more related to his PTSD and occur regularly. So back to his physical exam. He had no inguinal lymphadenopathy or lymph node tenderness in the inguinal node region. His penis was normal to inspection. There was no exudate. There was no erythema around the meatus. Nothing looked out of the ordinary there. We decided to do a digital rectal exam. His prostate was smooth, firm, rubbery, non-tender, no nodularities. It was symmetrical, heart-shaped. Overall, a pretty normal prostate. We also decided to do a pre- and post-void urine bladder scan. So pre-void, he had around 200 milliliters of fluid in his bladder. Post-void, he had about 70 milliliters. Ordinarily, in the geriatric patient, anything under 100 milliliters is considered normal, so that was fine. So as far as our assessment went, we were trying to decide whether this was an etiology of infection or of obstruction. So we decided to order some labs. We ordered a UA, a CBC, a creatinine, and a PSA test. So those will hopefully help rule out certain things and help us get closer to a diagnosis. We also questioned the patient about his fluid intake, his normal daily fluid intake, and he stated that he does not like to drink water. In fact, the only things that he really drinks are Diet Coke and whiskey. So we educated him that both sugary sodas and alcohol can be irritating to the bladder. We asked him to try to supplement his diet with 3 to 4 glasses of water a day, and to try to cut back on the soda and the alcohol. We also asked him, because we're still worried about residuals, to keep a bladder diary. We gave him a portable bedside urinal and asked him to record all the fluid that he drinks throughout the day as a log, and to also measure every void that he has of urine and to write that down in the log. Do that for about 5 to 7 days and then email us the results so we can look for residuals. We also wanted to start him on some tamsulosin for his prostate, to try to shrink that down and see if that might help his urination. So we prescribed tamsulosin 0.4 milligrams, 1 tab a day, 30 minutes after the same meal every day. And then we'll follow up with him in 4 weeks to see how that drug is helping, go over the results of his bladder diary, and overall just check in to see if his symptoms have changed. And by that time, we'll also know if there's an infectious process going on. So that was our patient. Thank you.